Ever feel like you just need to quickly get your head around something important? Understand the basics without wading through tons of detail.
Information overload is real.
Exactly. So that's what we're doing today. We're exploring the essentials of physical assessments across different ages.
Right. Based on this really useful chapter we looked at, it covers assessments from babies right through to teenagers.
Yeah, so think of this as our deep dive to pull out the key things to know, the different approaches you need for infants, kids, and adolescents.
Absolutely. And it's clear right off the bat that assessing a newborn is worlds apart from checking out a teenager.
Totally different.
The chapter really shows how the whole process changes, adapt to where they are developmentally.
Okay, so let's dive right into infants then. Birth to 12 months. One of the first things mentioned is how flexible the assessment order is.
Yeah, that's super practical. It's not like a rigid checklist. It really depends on the baby.
Yeah.
Are they sleeping, calm, agitated?
Right. So you prioritize based on that state.
Precisely. If the baby's calm or asleep, you go for the things that need quiet first.
Like heart and lungs.
Exactly. Heart, lungs, abdomen. Get that crucial listening done while you can, without causing distress.
Makes sense. Then what?
Then you'd probably move on to the head, face, neck, then eyes, ears, nose, throat. After that, hips and extremities.
And the more potentially upsetting things are last.
Yes, things like taking their temperature, looking in their ears, or doing the moral reflex check. Save those for the end.
Okay. And this brings us to those fascinating neurological reflexes in infants. They tell us a lot about development, don't they?
They really do, like the rooting reflex.
Yeah, explain that one.
Well, if you gently touch the baby's cheek, their head turns towards the touch, kind of searching.
Like looking for a nipple.
Exactly. And that one usually disappears around 4 months old.
And what does it mean when these reflexes disappear?
It's actually a good sign. It shows the central nervous system is maturing. They're moving from these automatic responses to more voluntary control as their brain develops.
Interesting. Then there's the sucking reflex. Pretty obvious, right? Finger or nipple in the mouth.
And they start sucking strongly.
Yeah.
And the chapter doesn't give a specific, disappears by time for that one.
Which makes sense, I guess. They need it to eat.
Right. It's essential for feeding for survival.
Mm-hmm.
The automatic part might change as feeding becomes more intentional, but the ability stays.
Got it. What about the palmar grasp?
Ah, yes. You put your finger in their palm.
And they grab on tight.
Yep. That cute little grip. It usually fades by about 6 months.
Okay. And the Moro reflex, the startle one.
That's the one. If a baby feels like they're being dropped, even slightly, or there's a sudden noise or movement,
Their arms fly out.
yeah, arms extend out, then they bring them back in, almost like they're hugging themselves. That usually goes away by around 4 months, too.
Why did they even have that?
Well, the thinking is it might be an old reflex from our primate ancestors, maybe helping baby monkeys cling to their mothers. Its disappearance shows more developed protective responses are kicking in.
Huh. Okay, last one on this list, Babinski.
Right. You stroke the sole of the foot from heel up towards the toes.
And the big toe goes up and the others fan out.
Exactly. And what's key here is that this is normal in infants.
Normal.
Yes, usually until they're about 2 years old.
Yeah.
If you see that response in an older child or adult, it can signal a neurological problem. But in a baby, it just reflects their developing nervous system pathways.
Wow. Okay. So those are the reflexes. But even before all that, right after birth, there's the APGAR score. Sounds important.
Oh, it's crucial. It's done at 1 minute and 5 minutes after birth. It's a quick snapshot of how the baby is transitioning to life outside the womb.
And APGAR is an acronym, right?
It is. A for appearance or skin color, P for pulse heart rate, G for grimace, that's their reflex irritability, how they react to a little stimulation.
Okay.
The second A is for activity, which means muscle tone, and R is for respiration, their breathing effort.
And how's it scored?
Each of those 5 things gets a score, 0, 1, or 2. So the total score can range from 0 to 10.
And what's a good score?
Generally, a score of 7 to 10 at that 5-minute mark is considered normal. It means the baby's doing well. Lower scores mean the baby needs some help, maybe immediate medical attention.
Got it. A really quick vital check. Okay, let's shift gears now. Moving on to children, say, 1 to 10 years old. The chapter really highlights a change in approach here.
Yeah, definitely. It becomes much more playful and interactive,
Mm-hmm.
especially with the younger ones, the toddlers and preschoolers.
Why is that so important, just to make it less scary?
That's a huge part of it. Anxiety and fear can totally derail an assessment with little kids. A playful approach builds trust, makes them less worried, and honestly, you get a better, more cooperative exam out of it.
Right. It meets them where they are developmentally.
Exactly. You're working with their way of seeing the world.
So what's the general flow for an assessment in this age group? Is it still least invasive first?
Absolutely. That principle still holds. You usually start just by watching them. Yeah, how are they acting? Playing? Walking? You can learn a lot before you even lay hands on them. Then you'd probably get vital signs.
Okay.
After that, usually listen to the heart, lungs, abdomen, then the ENT stuff, ears, eyes, nose, throat.
And musculoskeletal and neuro checks come later.
Typically, yes. Those tend to require more cooperation, so often they're saved for last.
The chapter gives some great practical tips for positioning and talking to kids across this range. Let's break that down. Toddlers, first 1 to 3 years.
Okay, toddlers. Big thing is security. Keep them on the parent's lap, if possible.
Because of stranger anxiety.
Yeah, it's usually pretty high at this age. Also, letting them see or even touch the stethoscope or otoscope before you use it can help. Demystifies it a bit.
Makes it less threatening.
Right. And simple words, maybe a bit of distraction, that's key.
Okay, makes sense. What about preschoolers? 3 to 5.
With preschoolers, you can bring them into it a bit more. Offer simple choices,
Yeah.
like, should I listen to your heart first or check your tummy? Giving them that little bit of control helps a lot.
Right.
And using imagination works well, too. Let's see if Teddy Bear needs his ears checked first, or this light is like a little spaceship looking in your throat.
That's clever. Okay, then school-age kids 6 to 12. They're getting older, more aware.
Yes, they can usually sit on the exam table by themselves. The big shift here is clear explanations.
Tell them what you're doing and why.
Exactly. Be honest, use age-appropriate language, and respect their modesty. That becomes really important now. Offer a gown, ensure privacy.
Got it. Okay, final age group. Adolescents. 11 to 18. The chapter says the assessment starts to look more like an adult exam.
It does, in terms of the physical components.
Mm.
But the approach is critical. Professionalism, respect, a non-judgmental attitude, these are paramount.
Especially because you might be discussing sensitive topics.
Precisely. And recognizing their growing independence is key. Offering privacy during the exam is a big part of that.
You mean offering to do the exam without a parent present?
Yes, if it's appropriate and the adolescent consents, it creates a safe space. They might open up about things about sexual health, substance use, mental health that they wouldn't mention with a parent listening.
That makes a lot of sense for building trust.
It's crucial. And just like with younger kids, but maybe even more so, you need to clearly explain every step of the physical exam.
And you mentioned those sensitive topics. This leads into the HEAS assessment tool, right? What's the purpose of that?
So HEAD is a framework, basically, a structured way for healthcare providers to check in on an adolescent's psychosocial well-being, not just their physical health.
Because it's all connected.
Deeply connected. Their home life, school, activities, potential risks, it all impacts their overall health. HEAS helps systematically explore those areas.
Okay, let's break down the acronym.
Each. H is for home. You ask out, who they live with, what relationships are like at home, any big changes like a move or divorce.
E.
First E is education or employment. How's school going? Do they like it? What grade? Or if they're working, how's the job?
Second E.
That's eating. Asking about their typical diet, any big weight changes, any worries about restricting food or binge eating.
Okay.
Activities. What do they do for fun? Sports, hobbies, friends. Also touches on social media, screen time. D is for drugs. This covers alcohol, tobacco, other substances. Do their friends use them? Have they tried anything? How often? Why? It's about understanding exposure and use patterns.
Right. That leaves the 3 S's. First S.
Sexuality. Are you sexually active? If so, what about protection? Condoms, contraception. Do they feel safe in their relationship?
Okay, second S.
Suicide and depression. This explores their mood. Have they been feeling sad, down, anxious? Importantly, have they ever had thoughts about hurting themselves?
A really vital area. And the final S.
Safety. This covers a range. Do they wear a seatbelt, a helmet when biking? Have they been in physical fights? Do they feel safe generally at home, school, and their neighborhood?
Wow, that covers a lot of ground. It really paints a picture of their whole world.
It's designed to. And the chapter gives some tips for using HEAS well.
Like what?
Well, a big one is using open-ended questions, not just yes, no. Ask, how is school going? Instead of, is school okay?
Gets more information.
Exactly. Also, start with the easier topics. Home, school, activities, build some trust before getting into, say, drugs or sexuality.
Ease into it.
Right. And crucially, Confidentiality.
Hmm.
You need to assure them their answers are private, but also explain the limits.
What are the limits?
Basically, if they reveal something that suggests they're going to seriously harm themselves or someone else, or if someone is harming them, you might have a legal or ethical obligation to report that to keep them safe. You have to be upfront about that.
That clarity is so important for maintaining trust even when discussing difficult things.
Absolutely.
This has been, wow, a really insightful run through from infant reflexes to these complex adolescent conversations. It really underscores how much the assessment approach has to change.
It really does. It's all about tailoring it not just to age, but to their specific developmental stage and needs. Understanding these differences is just fundamental to giving good care.
Care that's thorough, but also, sensitive.
Exactly. And that HE's tool, it really drives home that for teenagers especially, health is about so much more than just the physical body.
So, thinking about everything we've covered, it feels like the core goal is always connection, right? Building enough trust to gather the information needed, but doing it in a way that respects who they are at that moment.
Yeah, that's a great way to put it. Creating that safe space, that trusting relationship, allows for that comprehensive understanding of their health, their well-being right then and there.
So here's something to think about then. Considering these huge shifts in approach, from checking reflexes on a sleepy baby to discussing safety and mood with a teenager, what do you think is the single biggest change in focus for the person doing the assessment? And why is understanding that shift so absolutely critical for actually providing effective, compassionate care across that whole span of childhood and adolescence? Makes you really appreciate how healthcare adapts, doesn't it?